For those that are just joining now, thank you so much for tuning in. This is the 17th installment of the PhenoTips Speaker Series. Today, we're talking about improving patient experiences in clinical genetics. A note from our sponsor of the series, PhenoTips. PhenoTips is a complete solution for medical genetics. PhenoTips has designed software and services that ease genetic professionals' workflow. Tools like pedigree builders, human phenotype oncology capture, and diagnostic insights. Many of us, if not all of us, have struggled with EMRs, EHRs, electronic health records, whatever you're calling them, because they're not necessarily built for genetics and for all of us working in genetics and genomics. So PhenoTips is able to fill in these gaps by providing a unified and seamless genetics workflow. And in light of the pandemic, that's how this webinar series started. PhenoTips is sponsoring our speaker series here. And as I mentioned, I'm your host, Kira Deneen. I'm also the host of DNA Today, which is a genetics podcast that I've hosted for the past 10 years. We've won the Best 2020 and 2021 Science and Medicine Podcast Award, and we have very similar conversations to the ones that we're going to have today in this webinar. So feel free to check that out, dnapodcast.com. There's over 170 episodes on there. And I'm also a prenatal genetic counselor. So that's the background that I'm coming from. So enough from me. I'd like to hear from each of our panelists just for them to be able to introduce themselves to you. And then we can get started we have a lot to talk about today. So Dr. Campbell, would you like to start with introducing yourself to our listeners and viewers here?
Sure. I'm Ian Campbell. My pronouns are he and him. And I am a clinical geneticist at Children's Hospital of Philadelphia. I specialize in neurodevelopmental disorders. And then I also am a physician scientist and study both access to genetic care in the clinic and also try to make discoveries in rare disease.
Fantastic. Dr. Kumar, would you like to continue?
I'm Ajith Kumar. My pronouns are he and him. I am a genetics consultant based at Great Ormond Street Hospital in London, UK. I have an interest in both rare diseases and cancer, with a special interest in neuroendocrine tumors, and also an interest in using information technology to improve patient experience.
All right, and to finish us off, Dr. Chaudhari.
Hi, Bimal Chaudhari. My pronouns are he and him. I'm a clinical geneticist as well as a practicing neonatologist at Nationwide Children's Hospital in Columbus, Ohio, but I'm also a physician scientist, and I study ways that information technology and computational methods can improve the delivery of genomic medicine in acute and critical care settings. So I actually focus on inpatient genetic testing as opposed to the ambulatory setting,
which we're going to get into later in our installment here. And I love the focus on rare disease as well, as it's Rare Disease Month. So hopefully we'll be able to cover some of that as well. So thank you all for introducing yourselves. And as a reminder, as we get into questions that I have a lot of questions, but I want to prioritize your questions as the viewers. So feel free to submit those in the Q&A box during our talk today. I wanted to start the conversation today by talking about and identifying what are the biggest challenges that patients face in clinical genetic care so that we can start at this point and see where we want to go from there. Anybody want to start us off in terms of identifying some of the biggest challenges that patients are facing? All right, Dr. Chaudhari, do you want to start?
Yeah, so I have a perhaps somewhat controversial take on this, but I think the biggest barrier is actually just getting folks in the door. I think that clinical geneticists and genomic medicine in general, we've made tremendous strides in terms of recognizing appropriate testing and really shortening diagnostic odysseys once folks get to us. But I think that there is a lot to be gained by actually getting people in the door. They're essentially people who don't even know that they could benefit from genomic medicine. And so this is the one and only figure that I'm going to toss up to share with your viewers. But this is unpublished data from an ongoing single center study at our center, looking at the odyssey from admission to our hospital to the endpoint of their inpatient genomic medicine diagnostic odyssey. And so on the horizontal axis are the individual cases. This figure was drawn for the first 97 subjects. And on the vertical axis is the number of days. 0 day is the day that samples were actually sent to our lab for rapid genome sequencing. And so positive day counts are times that our research lab had the sample and were working to at least produce a preliminary result. And the negative days are all the days that the child was in the hospital, but didn't have samples that had made it to the lab. And you can see that most of the variability at this point at a single center that has a rapid genome sequencing program is actually in the time from admission to consultation with the genetics service, which is the beige bars, or the time it takes our genetics consultants to actually recommend rapid genome sequencing, the pink bars, or the time it takes to actually get the samples for the trio, for example, to the lab, which is the purple bars. And so we're really good at making sequencers go fast. And geneticists are pretty good at seeing patients for inpatient consultations. We really struggle still to get people to the geneticist door. And so I think that's one of our biggest barriers, actually.
And how do you think that we can start approaching this in terms of resolving this issue? Because you're saying that once a genetics healthcare provider is with a patient, things move fairly quickly, especially in terms of testing. Turnaround times are really fast compared to what they used to be. But the issue that you're identifying, correct me if I'm wrong, is just getting them to actually see that provider and identifying who needs to see a genetics provider.
Yep.
What do we need to change? Do we need to change the education of more healthcare providers to know, oh, this is a genetics case? Or do we need to change something on our end as genetic providers to be reaching out to patients? I mean, what are your thoughts on how we can start to address this?
So I'd be eager to hear what my colleagues have to say, particularly if there are different solutions that are present in the context of the NHS. But I think that, sure, part of it is potentially education, for these are who needs to be referred. But I think parts of it are also likely things like, can we leverage electronic health records, which are not necessarily designed to recognize rare disease patients, but can we recognize them to have EHRs trigger people who need engagement with the genomic medicine service earlier? Or do we need to move the delivery of more and more genomic medicine services out into primary care settings and start that process earlier?
Yeah, Dr. Kumar, definitely jump in.
So even in a publicly funded healthcare system like the NHS, access is a big problem. And particularly practicing in a city like London, where about 35% of the population were born outside of the UK. So there are lots of factors like language, cultural factors, socioeconomic factors that come into play as well. And also the issue of the turnaround time of tests. So we had a model whereby patients needed to get referred to the clinical genetic service before they could have a test. Now we are moving more towards mainstreaming of genetic testing. So for patients to have genetic testing within the context of the specialty they were originally seen in. So that is making a difference, but there's a huge amount of training and teaching that needs to go alongside that. Yeah, I mean, I think access is a problem even in the NHS.
Yeah, definitely. And I see in the chat, I just wanted to bring up, because this is relevant, that Anne in the chat is saying, I think getting people in to see genetic providers could better workflow if the referring provider explained to the patient and family better why they are being referred. We have a high no-show rate at my clinic because patients don't know why they were referred and why it's important that they be seen. We also need more providers. So I think that's a good point that we'll probably reference multiple times. But yeah, I see that even I'm working in the prenatal setting, but certainly a lot of my patients come and sit down. They're like, why am I here? Something wrong? And I'm like, most of the patients that I see, no, this is standard. I see all patients. But I think just having patients understand why they're going to an appointment and why it's important. I think Anne highlights a really, really good point there. And just for the patients to understand, because oftentimes patients show up to appointments and they're like, I don't really know what I'm doing here, but I guess I'll find out. And if it doesn't seem very important and they've got other things going on in life, they're not going to prioritize it. Anything to add to any of this, Dr. Campbell?
Yeah, I mean, I think that that it's not a controversial position that you stated there. That that once a sample arrives in the lab, we're really good at coming to a diagnosis. But getting the patient to the care team is a major challenge. And I think what we would call clinical decision support, where we try to help other clinicians nudge them towards the right way, is definitely the future of genetics care, to get them in the door, so to speak. And in my opinion, empowering the referring provider to have the information to explain why that referral is necessary and setting it up for success so that those no-show rates are lower is going to be critical to the part. Not only is it important to identify the appropriate patients that need the referral, but also empower the clinician that is acting on that information to get them to the front door.
Yeah, I think that's important, and figuring out ways that we can provide information maybe to these healthcare providers to say, here's a pamphlet or something to say, this is why it's important. And obviously it's going to differ per patient. But what are the main points of why someone's being referred to see genetics? And we've kind of touched on this a little bit, but I really want to dive into it because we do have providers here from the US and the UK. So I want to learn a little bit more about what challenges are unique to both areas, and if there are aspects of the healthcare system that we can learn from each other and be adapting. Dr. Kumar, you're coming from, or sorry, Dr. Campbell, why don't you jump in with that?
Yeah, I think that the other critical challenge that we haven't quite addressed yet is, at least in the ambulatory setting in the United States, insurance authorization is a major piece of the puzzle when it comes to genetic testing, because in our healthcare system, genetic testing is expensive, and our healthcare system is opaque in how much things are going to cost. And so that uncertainty around cost and being able to get the authorization for those things is a critical barrier for at least ambulatory testing. And so I think trying to work through those issues is going to be vitally important. And maybe we can learn from our colleagues who have more nationalized health systems on the benefits of making that work.
Yeah, certainly. Anything else to add in, Dr. Kumar? Go ahead.
So in the UK, we used to have regional genetic services, about 25 of them, which have now been integrated into regional genetics laboratory hubs. So, and there are 7 of them now. And previously, each genetic service had its own criteria for offering genetic testing. And it used to differ from, one part of the country to the other. So more recently, a national genomic test directory was introduced, and it gives you the criteria for testing, and it also tells us who can order the test. And also, we use a panel app which is produced by the Genomics England. It's a crowdsourced resource where genes are identified, and fitted into panels that that we can then offer. And it works with the National Genomic Test Directory. So it keeps evolving all the time.
Yeah, definitely. Dr. Chaudhari, go ahead.
Yeah, so I guess first to say thank you to NHS and the Genomic Medicine Service for Panel App. So our rapid genome sequencing program heavily leverages Panel App to facilitate rapid analysis and resolution of cases. So we freely contribute and borrow heavily from Panel App within our own infrastructure. It's what I would say is within local institutions in the US, at least, I think that there are some alternative models that get at some of the concerns that Dr. Campbell raised, which I think are huge. They're the elephant in the room in the US, really. But we at least in Columbus are lucky enough that we've made an institutional commitment. So one, we have a genome center, so we don't need to worry about sequencing costs that much, at least for our exomes and genomes, because we do them ourselves. And so we charge ourselves at cost. But so we've made an institutional commitment that if a child is covered by a state health insurance program, which is essentially Medicaid in the US, there is no out-of-pocket cost for our families. So the hospital will just eat the cost for anybody, as long as the appropriate clinician thinks that it's medically indicated that the child get exome or genome sequencing, it will happen. And for our commercially covered individuals, the state of Ohio has a supplemental insurance program specifically for children with rare diseases and on diagnostic odysseys. And so we're able to sign them up. It certainly adds time because we need to get somebody to approve this. But essentially, since I've moved to Columbus, there has been no resident of the state of Ohio who hasn't been able to get testing for reasons of cost, because the cost is ultimately zero in terms of cost to the patient at the point of care.
Wow. That's not something we have in every state.
No, it is not. And so I say that partly because I'm incredibly proud of the institution and a commitment. It's a little bit of a, braggadocio there, but the other piece of it is that these are choices that societies and governments make about how we allocate resources, both within healthcare and without. And this is a choice that one locale has made, but essentially as a public-private partnership, to say that genomic medicine for children with rare diseases is so important that cost cannot be the reason that children don't get tested.
Yeah, I think that's really well said. And I'm just wondering, for that, is genetic testing costs, is that only in the rare disease diagnosis space, or is that for any genetic testing?
So it is for any genetic testing that is clinically indicated at the Children's Hospital. As a practical matter, that's almost exclusively rare disease genetic testing.
And I also want to make sure that I'm pronouncing your name right. Do you mind pronouncing that again for me?
Chaudhari.
Chaudhari. All right. Thank you. Sorry about that. Anything else to add in terms of differences between the US, UK, what we can learn from that?
One thing I've been puzzled by is, some of the private US companies offer big panels for $250, which is a lot more than the cost price for our NHS labs. And I don't understand, are they, undercutting other labs to gain market position?
Dr. Campbell, jump in with that.
Yeah, I think that this is another sort of elephant in the room, where there are these large multinational corporations that are assembling huge portfolios of sequencing data at losses. And so we have to wonder what they are planning to do with that data, because it doesn't make economic sense that they would offer a test at a loss unless there's some other piece of there has to be something in it economically. And so in some cases, that's obviously spelled out in their consent forms that they're partnering with a drug company. For example, they're offering this free panel because they have the opportunity to identify participants for a possible drug trial. And that seems like a sort of upfront, everybody can understand the economic logic for that. And you can discuss those benefits and risks with the patient. But in other cases, I think that the economics and the data plans are sort of not as upfront. And it's something that I think everybody needs to consider when they're sending off genetic testing to companies that are obviously not able to cover the cost of that test with the amount they're charging you.
Yeah, and this definitely differs depending on what setting someone is in. But even in the rare disease space, there are a lot of opportunities where within the US, there are different programs that offer, to cover the cost of testing, because as Dr. Campbell is highlighting, there's some incentive for that company to do so, working with a pharmaceutical company, or, they're working with directly like a rare disease organization. But I think it's really important for providers to be aware of the programs that are available depending on what space they're working in. so that we are taking advantage of these programs and being able to limit the cost for patients to be paying out of pocket, especially when some of these labs, it is very pricey. You see what they're charging the insurance companies and it just seems wild. Anything else before we kind of move on to differences between inpatient versus outpatient settings? All right, we'll just jump right into that. So there can be differences in the challenges between inpatient versus outpatient settings. What are some of these challenges? What can we see as being those differences between them? Go ahead, Dr. Campbell.
So I think it's worth mentioning that different institutions have different sorts of outlooks on what sort of testing is available in the inpatient setting, because a lot of times we're not reimbursed for genetic testing that occurs in the inpatient setting because it's not a separate line item on the hospital bill. And so in a lot of cases, the genetic testing that we recommend inpatient just becomes a cost that the hospital doesn't get reimbursed for, and it's just a loss. And so a lot of hospitals around the country, children's hospitals, have actually implemented utilization committees that sort of arbitrate whether or not genetic tests can be sent as an inpatient. And so, and we have one of those at the Texas Children's, or at Children's Hospital of Philadelphia, and I know that they've implemented those at Seattle Children's, I think also at Texas Children's. So I think that it's a serious issue if we're trying to limit the amount of inpatient testing, whereas other institutions are just able to send it on everybody, and so that just demonstrates a disparity in care just because you happen to live close to one or the other type of institution. And I think it's just worth saying how great it is that people can access that sort of thing in Columbus.
Yeah, and knowing for healthcare providers, if they're referring their patients, of where should they refer their patients, where maybe the patient won't have a cost of like, oh, if I send them to X university or program, they won't have to pay anything, versus if I send them to the other one. So I think that's also helpful to know where we're sending that. Dr. Chaudhari, do you want to jump in with that?
Yeah, I mean, and I think that Dr. Kumar probably has more valuable things to say, I think, because there's an interesting transnational comparison here as well. But yeah, Dr. Campbell, I mean, really hit the high points, right? Which is that at least in the US, in general, you should assume that you're not getting reimbursed, at least for the costs of inpatient genetic testing. And then what I will say is I came from Lurie Children's Hospital in Chicago, where we did have a utilization review committee. The model that we've adopted in Columbus, which predates my arrival, is that the utilization review committee is the medical geneticist. So if you want an inpatient exome or genome, you need a medical geneticist to sign off on it, but that's the extent of your committee. The only requirement that we've adopted is, a geneticist thinks that it is important for the child's care, full stop. Ideally, that means we're talking about results that are actionable during that admission. But we recognize that there are cases where, looking at the totality of a child's care and their expected post-discharge trajectory, that it is important to send genetic testing during an admission, even if we know it won't result until a week after discharge or something like that. And we have a small enough group of physicians as well in medical genetics. There's about 8 of us that take inpatient consultations, and the institution has placed a great deal of trust in us to be reasonable stewards of their resources. So, but as Dr. Campbell says, there are many different models and advantages and disadvantages to how we do this in the US, but I really do want to hear what Dr. Kumar has to say.
All right, well, go ahead.
I think in the UK, the difference between the outpatient and inpatient setting is the urgency, I suppose, when a child is acutely unwell. So we can send a sample off for a rapid trio exome. There is an approval process, but it's usually approved when a child is acutely unwell and is suspected to have a genetic condition. So I suppose that's the main difference between the inpatient and outpatient setting.
And how long would that approval process take?
email in response to that.
Okay, so it's not like days or anything where
No,
a child's
no.
waiting. Okay,
No.
so it's still able to be rapid there.
Yeah.
Yeah, interesting just to see the differences. And I think for the US, it's very difficult because we're so large and we have different healthcare systems and settings. For there isn't a standard way. But certainly, as we've talked about, there's pros and cons to a lot of this. When talking about insurance, are there any specific coverage for testing or treatments that you would like to see increased? I guess more, on the US side of things, because insurance is, there's a lot of issues with them and we're battling with them in terms of what should be covered. But is there anything in particular that we really think insurance needs to be covering this, and it's really irresponsible for them maybe not to be covering that? Go ahead.
I'll bite. So I think everybody's going to guess all of my biases, but I think that the group at Rady Children's, led by Stephen Kingsmore, has done a tremendous amount of work quantifying the diagnostic yield and clinical utility of rapid genome sequencing in critical care populations, at least, and particularly in the NICU. They've also done a great deal of payer engagement, right? So credit where credit is due. They've worked with Medi-Cal, which is California Medicaid, as well as a number of other state payers around the country to increase coverage, reimbursement, or recognition of that. And there are now commercial payers who are partnering with specific labs or doing other efforts to increase the utilization and early utilization of rapid exome or genome sequencing in the ICU setting. So that would be the most obvious way that I think we can improve coverage. And then the other is on the other side, if we make diagnoses, so improved coverage for medical nutrition for our metabolic patients. Again, so I don't follow any of our metabolic patients long-term. We have a metabolic clinic of board-certified metabolic docs who see them, but I certainly make these diagnoses in the NICU. I'm sure that Dr. Campbell does if he sees inpatient consultations. It's one thing to give them metabolic formula while they're in the nursery and set them up with the G-tube and everything else. But this is a lifelong nutritional commitment. And for these patients, food is medicine, and it's just not covered well in the US.
Yeah, and sometimes it can be very, very expensive, these special formulas and everything. It's not something that is, a lot of people are accessing. So it becomes like, that supply demand of just being very expensive. So I think that's a good point, and one that I haven't heard raised really. So I think that's a good one to be bringing up. And Dr. Kingsmore has been on the show before. So really, fantastic viewpoint there and everything. So people can go back and listen to our older episodes to hear his viewpoints and everything. Switching gears a little bit because, sorry, Dr. Campbell. Jump in.
Yeah, I think that absolutely we need to get more coverage, and I don't want to make this sound like it's a genetics only problem. It's an entire American healthcare industry problem, but the whole process of prior authorization for genetic testing is just, it really is a travesty, because even at the end of months of negotiation with an insurance company, they may tell you that they aren't going to tell you whether or not they'll cover the genetic testing until after you do the genetic testing, which just is like, to me, just seems like, how do we have a healthcare system where you can't know if your patient can have the thing until after they've had it?
Yeah, which is kind of wild, because when patients ask me about that and I say for certain things, like, we don't know how much it's going to cost until you do it. It's like nothing else in the world works like that. You don't go to buy a car and then they say, oh, well, we can't tell you how much it is until you owe us money. Like, that's not how it works. You learn about what are the prices for each car. You decide what works best. You shop around. And it, our healthcare system doesn't work like that. And genetic testing is, I think one of the main problems with that, of just not having transparency with costs. And some labs offer like cash pay prices and different things there to help, you always have that option. But yeah, it's very difficult to get a price before you actually send the sample. And some people may not really be able to afford that, or that's really going to impact their life. So I think that's a really good point as well, that I think we're all experiencing. Anything else before we kind of move on to different area of patient experience? All right, I'll go ahead. So I wanted to talk a little bit about what healthcare providers should keep in mind in terms of pretest counseling and obtaining proper consent. So some things that we've brought up here are people are coming from a lot of different backgrounds. Some people are going to have, working knowledge of genetics, whereas most are not. So I think that's, one area that I focus on in terms of, do I have this patient's informed consent? Do they really understand the testing that we're ordering and what the implications of that could be? Are there any tips or advice that you guys have in mind of what we should be keeping in mind to have that goal of having true informed consent, and what should be included in that pretest counseling part? Yes, go ahead.
So I think, and I sound like a broken record, right? But I think that there is an important difference between counseling in the acute and critical care setting as opposed to counseling in the ambulatory setting, for example, for static encephalopathy and a neurodevelopmental disability. And I'd be happy to see if Dr. Campbell or Dr. Kumar agree with this distinction. But like in the ICU setting, non-genetics professionals counsel about complicated tests with risks, benefits, and alternatives in time-sensitive, high-pressure situations all the time. Okay. Unfortunately, those same professionals, at least in my experience, know so little about genetic testing that they can't have that sort of hyper-focused conversation necessarily with parents, for example, of parents of critically ill children in the NICU. But I think that they have all of the other communication skills that I think there's this huge untapped workforce that we could upskill to expand access to focused, like really targeted pretest counseling in acute care settings, which is important because a lot of places don't have access to really great inpatient genetic counseling resources, right? Our institution, again, as part of my lab, we've funded, we have 2 FTEs. We have 2 genetic counselors that split their time between our fetal medicine clinic and the NICU. And so there's a genetic counselor who rounds in the neonatal ICU every day of the week, right? Which is not something that many NICUs necessarily have access to. And so I think that is very different, right? You can focus your counseling on, this is the reason for the testing. Here are the very high points. These are the potential outcomes of testing. You don't have to talk about what is the genome, what is the difference between an exome. Like, these are things that frankly parents in critical care settings just don't have bandwidth to do. You're not informing them by talking about those things.
You're overwhelming them at that point.
Yeah.
It's like they're going to probably be doing the testing. So yeah, as you said, like, what are the bullet points that we need to be highlighting? It's not a setting where, oh, they're coming in for a visit. Like, that's not the setting.
No.
Yeah.
No, the place where you need all of the extra skills and knowledge that genetic counselors come is if you can only choose between pre and post-test counseling. They're invaluable for post-test counseling, regardless of whether or not the testing is diagnostic or non-diagnostic. And the Australian acute care genomics study, I think, really highlights that. Parents tell us they want time to review genetic testing results with genetic counselors. They don't want care conferences. They want one-on-one time with a genetic counselor to understand the results.
Yeah. I think that's well said with that. And from your experiences, how are patients usually informed, either the patients or the caregivers, depending on the setting? How are people usually informed about the results? Because I know there's different approaches to this, either, a phone call by a genetic counselor or geneticist, or updated through a portal, or they have a appointment set and it's expected that results will be available to review at that appointment. What do you guys experience? How do you typically approach patient results? Dr. Campbell, yeah, how do you approach it?
I mean, I think that at least when I'm consulting in the inpatient setting, we try to set up a family meeting and deliver the results in person in the context of their ongoing critical illness, so that there can be a sort of update from how the illness is progressing, and then sort of putting the genetic information there in context, with the care, because as was stated before, there are other things that are more pressing sometimes, like if your child just had a major cardiac surgery, then the genetic test results may not be the highest priority in their mind. But in the ambulatory setting, I think that I've tried a number of approaches in my clinical practice, whether that's telephone calls by the genetic counselor, video visits, or in person. And I think that I personally find that the patient-physician interaction in person is the most ideal, but even asking the parents of my patients what they prefer, often will get totally different answers. Some people really value that person-to-person interaction, and then others really value being able to feel safe in their own home and be able to have their family there and not have to make the journey all the way to the middle of downtown Philadelphia. And so maybe there's a way to sort of tailor the results disclosure to the person that's receiving the results, at least in the ambulatory setting. But I'd be interested to see what other people think.
Yes, go ahead.
Oh, yeah, well, if Dr. Kumar wants to go ahead, I'm happy to.
I'm sorry, I've been having trouble with the internet connection. So in terms of giving out the results, we are flexible. In some instances, we give the results out by letter, if it's a completely normal result. But in some instances, we would arrange a follow-up appointment, especially if it's a positive result. We would, and in some instances, we pre-book an appointment slot to discuss the result. It varies from patient to patient.
Yeah. So I guess the other thing I wanted to bring up, and this is, again, a purely US thing, but the 21st Century Cures Act and the information blocking rule have sort of really had an impact on this and how we communicate results, because we do our own exome sequencing, for example. The results of the exomes are sort of transparently available in the patient portal for the electronic health record that our health system uses. And we do our best to try to, as part of pretest counseling now, includes information about the information blocking rule to try to get permission to embargo the results so that a clinician can review them and actually proactively disclose them, rather than having families just read the exome reports, which are not really written in a way that is meant to be consumed by a patient, right? And sometimes it works and sometimes it doesn't. The story that I tell is a colleague of mine actually brought their child to see me as a patient, and went through extensive pretest counseling. This was a non-genetics colleague, but a physician, and their child underwent exome sequencing, and they were fairly adamant that they and their partner wanted immediate access to the exome sequencing report when it was published. And they saw it, and it was a diagnostic finding, and they had so much regret after the fact that they saw this, and even with their education, could still were really, really stressed in ways that I think a geneticist and certainly a genetic counselor could have predicted, well in advance. But it is the law of the land in the United States.
Yeah, Dr. Kumar.
So we wouldn't release genetic test results automatically. So the clinician who requested the test contacts the patient.
Yeah, and I see that's often, what we're trying to do to avoid patients, receiving results without someone there to help interpret and process that information. Now,
I think it's just worth saying that like Dr. Kumar's reaction there is exactly what us as geneticists in the US feel too, and yet we are sort of at the mercy of legislation. And so I think that that's just a perfect example of how sometimes legislation doesn't match the clinical care, although there are the sort of workarounds of pre-test counseling that were mentioned before.
yeah.
So
yeah.
is it that you have to release a result immediately or within a certain time frame?
Immediately, though, unless you have explicit permission from the family to embargo the results, because they have asked you to embargo them, they must be made available immediately to the family at the same time they're made available to the clinician, which in practice, as one of the commenters in the audience points out, it means that not infrequently we have families that are looking at the results before a clinician is.
Yeah, and it's so tough because it didn't used to be that way. When I started practicing, results were covered up until I had time to call the patient and then release it to them within a portal, from a lab that I use. But now patients are calling me and saying, hey, I just saw my results. And, that's the way I used to have it set up, is that negative results would be sent out after 24 hours, like normal results. Because if for some reason I couldn't get to it in that time, I feel comfortable patient receiving normal results. But, for the positive results, I would have that, no, you cannot release that until I release it to the patient. But now that's just so different and certainly a challenge in genetics. Dr. Kumar, anything to add to this?
No, yeah, I mean, I can imagine how difficult that could be, if it happened here.
Yeah, you don't have time to just either do the research if you've never heard of the condition, or just get your thoughts together exactly how you're going to present this information, because, we also want to be using our counseling skills to be able to present this in, informative way, but also be, careful and respectful of human emotions and everything. So I think this is kind of a recent issue that's come up definitely in the US with that. So hopefully we're continuing to navigate this, and I don't know if there'll be changes hopefully in the future where maybe we can avoid that from happening. So in terms of some of the systematic barriers in accessibility of care, are there ones that we haven't talked about yet? I know we've identified some ways of just, as we started the conversation, of having the right patients be referred to genetics, and that being, one of the big barriers. But are there other barriers that are on your minds that we haven't discussed yet? Yeah, Dr. Campbell.
Yeah, one of the things that we haven't discussed is sort of the ability to access the healthcare system in general. And one of the studies we recently did in telehealth, comparing outcomes for patients seen in person to those seen by telehealth, is that sample collection, like actually getting the DNA, turns out to be a really big barrier, in that about taking into account both insurance authorization and actually getting the DNA to the lab, as many as half of patients that are sort of recommended to undergo testing never actually get a test done. And it seems like those seen by telehealth, because they're at home and it either takes a lot of energy to get that sample collection kit to their house and then back to wherever it goes, because we all have busy lives, and if you're working 2 jobs and you don't have time to be wasting with the UPS driver, then it's hard to make those things happen. And so I think that there's certainly the problem of getting patients in the proverbial door, but then there's that next step of authorization and sample return, which at least our preliminary analysis suggests there are determinants, socioeconomic status, what language you speak at home, those sorts of things that are going to really influence a lot of those barriers.
And Dr. Kumar. Oh, he might be frozen. So Dr. Campbell, I had a question with that then. So do you ever take advantage of like mobile phlebotomists that will come and do house visits to collect a blood sample, or saliva sample is sufficient so you don't really need to be including that?
Yeah, our health system has not yet taken advantage of these mobile phlebotomy services, which I am aware of, and I think our one of our chief technology officer is really excited about maybe partnering with one of these companies to see, because obviously it's not a problem that's just specific to genetics. There are a lot of different specialties where monitoring labs for, say, anti-epileptic medications are really important. And so it's certainly not specific to us in particular, but I think that, having somebody come to your house is, a way to really make sure that happens.
Yeah.
Because even when the genetic counselor that sees patients with me calls the family to remind them sometimes 3 times, and we know that the sample collection kit has arrived because there's a tracking, outbound tracking number, and they agree that they have gotten the sample, somehow people's lives are really busy. They've got a lot of things on their mind. They often have medically complex patients. Their children have medical problems, and maybe getting that saliva kit back to the diagnostic lab is not their top priority, understandably so. And so what we can do to align the priorities in the right way, I think will be important going forward.
Yeah, I think even in terms of sometimes having the kids sit down and give a saliva sample, and okay, they can't eat or drink for 30 minutes before. And, there are some things that you kind of have to line up in terms of your day. Dr. Kumar, anything else to add to this?
In terms of other factors, once we have made a diagnosis, supporting the patient and family, especially in the community, one problem with having a tax-funded system is that the resources are limited. So I'm thinking of, children who have chronic conditions who need to be looked after in the community. And sometimes you can run into difficulties there. Staffing is another issue especially with mainstreaming, more and more results are being generated, and, finding sufficient number of GCs to cover all these requirements and all these specialties is another barrier.
Yeah, certainly many that we could list, right? In terms of one area where something that might be helping us in terms of, patient experience and patient care, are digital tools. So like pedigree builders, pre-visit questionnaires. Do any of you use any of these types of digital tools? Do you see this enhancing the patient experience or making it just easier in order to get this information and the accuracy with that? Yeah, Dr. Kumar, why don't you start?
So we selected an EPR for our hospital about 5 years ago, and it became very clear that none of the leading EPR providers had a good genomics module. So that's how we came across PhenoTips, and our current EPR is being supplemented by PhenoTips. So one of the major problems I found with the EPR was that you could not code rare diseases. Essentially, the newer genomic diagnosis, it just couldn't code. It couldn't capture HPO terms. Our ophthalmology department had started gene therapy for a form of retinopathy, and they needed to identify patients who had mutations in a particular gene, which the EPR couldn't do. So to have something like PhenoTips where you can code genetic conditions, rare diseases, and not even PhenoTips has all the latest diagnoses, but it'll at least have the gene which you can capture on PhenoTips, and thereby extract data and identify cohorts of patients who would benefit from a new intervention. In this example, the gene therapy for RPE65. So that's been immensely helpful.
Yeah, definitely, because sometimes the standard electronic health systems are just not up to par with what we need to be working with. And I think with genomics, it's so specialized in terms of what we need in that workflow. So yeah, really glad that PhenoTips can help you, bridge a lot of these gaps and everything. Either of you have any other experience with digital
The other frustration
tools?
I have is, I don't.
Sorry,
the other
go
frustration
ahead.
I have is I have been telling the EPR provider that they need to have this on their systems. It's in their interest to have this, and I wouldn't be the only person asking for this, but it just hasn't happened in 5 years' time. Yeah.
And
Find
5
it
years
very
is a long
frustrating.
time in genetics. Yeah. Dr. Chaudhari, do you want to jump in?
Yeah, just to echo what Dr. Kumar said, when I joined the faculty here in Columbus, we actually brought in our current EHR vendor, which is one of the two major players in the US market, to talk exactly about these issues and to lay out the needs of pediatric genomic medicine and sort of rare disease genetics. And there was just a complete crosstalk. It was a discussion about a genomics module that was related to polygenic risk scores and, adult onset cardiovascular disease and, adult cancer predisposition syndromes, which, I mean, yes, there are centers where all of genetics is located in one center and it's not a pediatric oriented place, but cancer genetics is one slice of genetic medicine. It doesn't really touch the rest of the stuff. And just to echo what Dr. Kumar says, there's not, at least in my experience, a good model amongst the major EHRs. The one thing we do use is pre-visit review of systems checklists through our patient portal. I have found those to actually make my ambulatory visits, few as they are these days, actually much smoother because those things come pre-filled. And if I actually have time before clinic to even peek ahead of time to sort of reshape the visit, particularly for my unknown patients, to say, is any of the new review of system stuff change how I think about this patient or approach this visit?
Yeah, I do very similar things in terms of, what patient information I can have ahead of time, what questions they have or something to be able to, shift the visit into what I think they really want to hear from and everything with that. So yeah, really great just to hear how that, helps your side, but also the patients probably have a smoother experience being able to prep better for this and just being able to use the EHRs more smoothly with all of that. Another topic that has been, I think more relevant, especially in terms of the pandemic, is burnout. Unfortunately, it's very prevalent among healthcare providers. I think the pandemic has added a lot of layers of stress onto us, especially in genetics. How do you think this impacts the patient experience of just our own experiences with burnout and how that might then affect patients? Anyone want to jump in with this? I can move on to the next question. So go ahead, Dr. Kumar.
Well, I mean, when the pandemic struck, we were having discussions about whether to shift some of our clinics, to virtual. And then the pandemic hit, and within a couple of weeks, all our clinics became virtual. It was such a dramatic change, and thanks to the EPR plus PhenoTips, we could do it. We could do clinics virtually, and we didn't skip a beat really. We just carried on doing our clinical work. I mean, it's not ideal, of course. Patients who need examination, we got them to send in pictures. But it's not ideal, but still, we carried on. We saw most of the patients we needed to see that way. So yeah, that was a big plus at the beginning of the pandemic when most other specialists were struggling.
Yeah, or just not being able to see patients because they didn't know how to adapt. So it's great that PhenoTips was able to give you an option so that patients could still be seen and that it didn't impact the patient care as much as it would have if you didn't have PhenoTips and everything. So in terms of other, areas where we could be helping patients, I think one of them is just, understanding that it can be very overwhelming for parents, caregivers to be providing care and having their child be seen by all of these specialists. Are there any resources that you're aware of to help ease this burden? Are there any different tips you have in terms of identifying patients that could really benefit from a social worker or another healthcare provider that's more in this space? So identifying ways for them to be seen by a social worker and also just other resources for them just to make life a little bit easier. Yeah, go ahead, Dr. Chaudhari.
Yeah, so so I don't think that everybody in the sort of collection of patients you're describing actually needs a social worker necessarily, although I think they're wonderful. They're just hard to come by in my experience. But I think what a lot of places have done for medically complex families are things like the existence of complex care clinics that can serve some of these roles, the existence of care coordinators or care navigators, whatever they're called. So when I was a resident at the Children's Hospital of Pittsburgh and UPMC, I think the policy, at least at the time, was if you saw 3 or more subspecialists, you would qualify for care navigation services, and they would take on the burden from the family for making sure you could see as many people as possible on a single day, so that if you follow with 6 specialties, you're not making the trip in to see them on 3 different days on this week and 2 days on this week, and really disrupting the parents' lives and the family's lives, because their child has complex healthcare needs, but they're also people and they have lives and they want to get on with those things.
Yeah, definitely. And Anne's chiming in that that's how visit navigation still works at Children's Hospital of Pittsburgh. So you're still accurate with that. Dr. Kumar, what do you have to add?
So we have SWAN nurses, SWAN standing for syndrome without a name, who help these families, and sometimes they are no longer SWANs by the time they get to see the patient, because thanks to whole genome sequencing. And we also, for some time, we had a Lucy Booth Peanuts reference, for psychology counseling, you walk-in service. Unfortunately, it hasn't continued, but that, some families, and especially when they are in a very stressful situation and they wanted to have some support, that was one resource we could direct them to.
Yeah, I think that's wonderful, just to be able to provide resources and people that can just help with these processes, I think are really great. And I want to remind our viewers that I have a lot of questions, but I want to prioritize your questions. So I see a couple that have popped up in the chat, which we'll get to in just a few minutes. But if you have questions or a comment that you wanted to chime in with, please use either the chat or, for your questions, the Q&A box. So definitely put them in there so that we can get to it before we wrap up today. And let's see, we'll actually take the first question. So the first question is, do you envision a role for clinics services for undiagnosed conditions where genomics to date may not have provided an answer? So does anyone have a response in terms of looking at, a role for the undiagnosed conditions? Yeah, go ahead.
Yeah, I mean, at the moment, Genomics England hasn't made a formal plan to revisit some of these patients who have had whole genome sequencing and no mutation has been identified. So the pickup rate from the 100,000 genome study and the initial data from whole genome service, the pickup rate is somewhere between 35–40%. So 60+%. So the data is there. We'll have to revisit it at some point, but at the moment, the priority is to get as many people and older patients who don't have a diagnosis through the door.
Yeah, it certainly makes sense. Anything else before I move on to the next question we have in the queue here? All right, I'm going to go for it. Is the patient ability to selectively consent to embargo on the release of results in Columbus a hospital-wide policy or specific to the genetics service?
I am not confident on that answer. I believe it is available for any complex test that is available, but I cannot be sure, since, I'm a geneticist, so I know what I know.
Dr. Campbell might have an answer for us.
Yeah, in my other role as a clinical informaticist, I've got the pulse on our hospital at least, and that at Children's Hospital of Philadelphia, you can embargo the release of any test. Our EHR vendor has like a outstanding tests sort of like window where you can see all the tests that could potentially result, and you could be like, I want to embargo this one. And when you do that, you have to give a justification for why that might be. And one of the justifications we haven't talked about on this show yet that is written into the law is that there are other people's health information, protected health information in the result. And so an industrious lawyer might decide that a trio exome sequencing could actually be embargoed because it contains other human beings' protected health information. And so we're trying to decide whether our lawyers subscribe to that or not. But at the very least, if you have talked to the patient before you sent the test and they said it was okay to embargo it, then no problem. That's one of the reasons. The other big categories of reasons are harm, where, for example, if an HIV test, for example, came back and a parent saw that their child had HIV, that could result in some sort of domestic violence. That would be a reasonable exception to embargo results. But I don't think that many people have the current reading of that is that it has to be physical harm, not emotional harm. And so we can't really use that justification to block genetic test results. But I think maybe there will be movements in this space as this law becomes more of a reality.
And how does that work in terms of, there's kind of two different ways that a patient could theoretically get results. One, through like the actual hospital portal, so their patient portal. And second is directly through whatever laboratory is running it. So sometimes that might be the same. Sometimes it might be a lab within the hospital. But for a lot of genetic testing, a lot of people are sending it out to a different laboratory that's not within the same system. So that would be a different portal. When you put an embargo on that, is that only blocking it through hospital channels, or is it also blocking it through like the lab specific portal?
At least for my clinical practice and those of my colleagues, most of our results go through our send out lab. So there is no typical way that the patient themselves accesses the reference laboratories portal. So we thankfully don't have to worry about both directions, but I can imagine that other people that utilize those sorts of labs would have to worry about that.
Yeah, I'm kind of thinking for myself, like if I were to do that, how would that work? So as we've been, talking about, there's a lot of different ways that we can improve the patient experience and their care. And I think one part that we haven't talked about is incorporating patients' feedback, and obviously including the caregivers in this as well. Are there modules, methods that you guys have seen that are successful? Is there any ways that your department is receiving feedback from organizations? I know Care Opinion in the UK or the Picker Institute is kind of on that list in terms of, on the UK side. Go ahead, Dr. Kumar.
So within our department, we have been doing patient surveys and each year focusing on particular aspects. And this year, we did it electronically, and it was focused on virtual consultations versus face-to-face consultations. So 2021 gave us an opportunity to compare the two. And generally, virtual consultations were well received. Especially, if you have an unwell cancer patient who doesn't want to come into a hospital to be seen and counseled, or a family with young children not wanting to travel, for a result, for example. I think selected use of virtual clinics have been successful, and we intend to continue that in the future.
Yeah, that's definitely been a recent addition to how we all operate and meet with patients there. Anything else that you see as being a good way to incorporate feedback? Yeah, Dr. Chaudhari.
Yeah, so what I will say is on the ambulatory side, we participate in our hospital's patient feedback sort of system. I can't remember if it's Leapfrog or who does it for us, but I'm dubious of its value. Occasionally we get people actually write something on them, and they're generally nice pats on the back, or occasionally lay out something genuinely egregious where we look and we're like, oh, we can't be doing that. But most of it is the circling of these numbers on these boxes. I'm not convinced they actually correlate with anything meaningful for patients or families. But at least on the inpatient side, in the NICU in particular, we have a parent group that is facilitated by a psychologist that the hospital pays a salary for, that sort of acts as an advisory board. And it's not specific to genetics or genomics, but as a neonatologist, I have access to them. And as somebody who does research in the NICU, I have access to them. And they've given us some really good feedback. And so one of the things they identified was, I think, something Dr. Campbell touched on, which is if you want to do trio testing, which is the ideal for a rapid exome or genome in the critical care setting in particular, you've got to draw the parents and the child. And our standard of care has been for a long time that our parents essentially get registered as ambulatory patients and they wander down to the outpatient lab and get drawn whenever. But the parents essentially told us that they come to the hospital when they can, because some of these parents, they have jobs that they can't take indefinite leave from. Their kids can be in the NICU for a long time. So they work during mostly normal business hours. They get here when they get here. And when they get here, they don't want to leave their kid's side because they have been told repeatedly, and not, in a well-meaning way, that your child is at risk for death. And they're like, look, I ain't going to the outpatient lab. I'm going to hold my baby's hand today. And we know that, for example, it takes a median of 2 days from the time that counseling is completed in our facility to collect parental samples. And it takes less than 2 days to do rapid whole genome sequencing. So, we've taken that feedback and we're looking at innovative ways to do this. Can we get other staff? Can somebody actually draw the parents like in their child's room? But that is feedback that was totally initiated by the parents who just said, look, you asked us why we take so long to go to the lab. It's because our kids are sick, you dummies.
Right. Yeah. And sometimes we don't realize that until we hear from patients, and then we're like, oh, that's common sense. Of course. Why didn't we think of that? But sometimes it takes patients speaking up for us to even realize that. So yeah, hopefully on that side, some of the phlebotomists can take a walk and head over to the NICU and be able to draw people right there. But Dr. Campbell, did you have something else to add to this?
I just wanted to say that I agree that the number circling on our Press Ganey feedback is largely a pat on the back, but I think there is some information there because the lowest marks that we used to get were access to care, and with the development of telemedicine, those numbers significantly improved. So I think that it does suggest that there is some real data in that, but I agree. I question if we're going to make giant revelations from those sort of generic customer satisfaction surveys that we sent.
Yeah, I think sometimes, if we're going through and giving 1 out of 10, rating on everything, that it's not necessarily going to give us like an actual action that we need to change. It's certainly good to know what we're doing well, but I think it's even more important to know what we're not doing well. And that I feel like you're only going to get from like a free written response, because otherwise, it's probably not on our radar. And then it's not going to be one of the line items, that we've talked about there. So we have just a couple minutes left. If anyone else viewing has a question, feel free to pop it in. Hopefully we'd have time here to answer. But I wanted to kind of end, yeah, go ahead.
Sorry, I don't want to interrupt your ending, but can I ask a question? I really actually do want to see if Dr. Campbell has a minute to throw up what he wanted to talk. We were briefly talking about before the public session started, because I was actually really excited about what he had.
Yes, thank you for reminding me. Yeah, Dr. Campbell, go ahead.
Yeah, I think that one of the other things that is a major barrier to access to care is that the process of diagnostic odyssey is like really complicated, and there's insurance authorization, there's clinical evaluation, there's sample collection, there's making sure that sample makes it to the lab, there's seeing that the results have actually happened and then communicating those results back to the patient. And I'm just gonna quickly share this little diagram that we put together for a study. And a lot of times we can actually miss diagnoses. And even at a place like the Children's Hospital of Philadelphia, where we try really hard to do really great genetics care, sometimes the little holes in the Swiss cheese model that any of the clinicians will have learned about sort of line up, and then we miss genetic diagnoses where, you know, maybe we were supposed to get the results in our in basket and that broke for whatever reason. And a lot of genetic counselors I know learned in genetic counseling school that you keep up with your patients on a big Excel spreadsheet. But if you see thousands of patients, like you can't keep going back and forth between your electronic health record, your portal, and your patient list. It's just not possible. And hopefully there's like a primary care team member, like a pediatrician or an internal medicine doctor that knows that this evaluation is going on, and that you know, hey, what happened to that? And then the family hopefully knows, obviously, that they are undergoing genetic testing, but especially in the critical care arena, you know, maybe there are bigger issues that their child is having going on. And so if they're worried about that major cardiac surgery, maybe they forgot that we sent this genetic testing. And so when all those line up, you know, there's the chance for a missed genetic diagnosis. And so we came up with a comprehensive genetic test tracking system that is the replacement to that Excel spreadsheet, where we have a form in our electronic health record where you very quickly can indicate what you recommended for that patient. And then there's sort of like a dashboard where you can see all of your outstanding patients, where in the diagnostic odyssey they are, and quickly see like where the genetic test results are. It's sort of been an agile development cycle where the genetic counselor who works with me, shout out to Morgan McManus, has really helped me in improving the system. And we've gotten feedback from across the division to see sort of how we can improve it. And you know, it actually works. Here is a graph of whether or not we look at the results for a patient after the genetic test results. And on the x-axis is the number of days since that result was available. And then the y-axis is the percentage of patients that we actually looked at. And so here without the tracking system, you can see that we sort of miss a few percentage of patients. They sort of slip through our fingers. But with the tracking system, we can catch all those patients. And so I think that having an integrated way to see all the patients at a bird's eye view is something that a lot of the EHR vendors could do a better job of.
That is just fantastic.
Does that include samples, you know, done in-house as well as samples sent elsewhere?
It was originally developed for our inpatient work because that was the sort of hardest hitting, but we've since sort of expanded it to the ambulatory setting to also take into account insurance authorization and all that. And I see that somebody has already wondered if this is an Epic institution, and yeah, I think in the near future, hopefully we can work with our colleagues to set up a way for it to be more broadly accessible, but I'm glad that people are interested.
Yeah, I gotta say, when I round as a neonatologist or take on service, I usually cover our medical ICU team and our neuro ICU patients. And I've got to say, there is at least one patient per week when I show up on service where there's a progress note that basically says, genetics consulted, testing pending, exome pending. And I was like, oh, let me find out. Sometimes it will say enrolled in rapid genome sequencing study. I was like, I'm the PI for that study. Surely I would know about this pending result. And you realize that they've actually had a genetic, they've had a molecular diagnosis for days, if not weeks, sitting in the patient sitting in the ICU. And it's not clear who does or doesn't know that this has actually happened, which is terrifying.
Yeah, and so impressive that Dr. Campbell, you were able to develop this to eliminate patients like that of slipping through the cracks and everything. This is really exciting to look at. So I really want to keep up with, you know, how this ends up being implemented in other places too. I think there's a lot of buzz about this.
Yeah, and I think the the sort of example of what you just described as happening is the exact reason why we tried to implement this, because it's not something that's unique to your institution. It happens everywhere, and I think that we can all identify.
Yeah, definitely. Well, thank you all so much for coming on and sharing all of your expertise. I think we were able to dive into so many different areas of patient care and how we can improve that experience for patients and caregivers. So everybody viewing, you will see a feedback link in your browser when this webinar ends, as well as it being emailed to you. So please, we would really appreciate if you could take a minute to offer feedback so we can work to improve our upcoming series. The email will also include a link to the PhenoTips Speaker Series page, where you can also sign up to receive alerts on upcoming sessions. And if you want to access this at a later time, you can go to phenotips.com, click the resources tab, and the speaker series will pop up on the drop-down menu. And all the installments are on there, as well as the video aspect. So it's not just audio, but also it's available as a podcast too. So you can search for it that way if you're more of an audio person like me. The email will include a link to register for our upcoming March webinar. So set your calendars, March 24th, we're going to be talking about improving diagnostic yield in pediatric genetics. So focusing more on the pediatric side, kind of as we've done in this episode today. So again, thank you very much, everybody, for tuning in. Again, I'm going to give a shout out to my podcast called DNA Today. You can access that by searching DNA Today in your podcast apps, or by going to dnapodcast.com. Anything else to plug in terms of websites or anything else before we officially close out this episode? All right, I guess we are set then. Thank you, everybody, for tuning in for our 17th installment today. We really appreciated hosting you, and we look forward to seeing you on March 24th.